This is the last set of webinars covering the blood, and in this webinar we're going to discuss the process of hemostasis, which literally means stopping of blood. So hemostasis is a process in which we're going to try to limit blood loss. So it is an example of positive feedback. In AMP1, you discuss negative feedback mechanisms and positive feedback mechanisms. Remember, a positive feedback mechanism is going to amplify your body's response to a stimulus until eventually a negative feedback response will take over. So what your body does is it senses a change, and it's going to activate a mechanism that accelerates or increases that change. But we always, it's kind of enclosed in a, what I would say, a larger negative feedback loop, because at some point you need to get that blood, the blood to stop, and you want to limit the actual clotting of blood. So there are going to be a few phases that we're going to look at, and you have them listed in order. So we start off with what happens at the level of the blood vessel, then the platelets get involved, then we're going to have the coagulation phase, which is actually the forming of the blood clot. But at some point you want that clot to kind of retract, you want to repair the vessel and dissolve the clot. So we're going to look at this picture. So we're going to see the vascular phase and the platelet phase together. The vascular phase has to do with the blood vessel itself. Direct injury to the blood vessel leads to a vasospasm, in which the smooth muscle, which kind of runs in a circle around the blood vessel, is going to contract, which kind of narrows the lumen of the blood vessel, and it's going to help to limit the blood loss. And what triggers that is local factors that are released by the tissue damage that will stimulate the smooth muscle to contract. There's local reflexes that take place, but then very shortly after that, it's going to be followed by a platelet phase, which involves the platelets. The platelets are going to help to form a plug. But actually, before I continue that, is one of the factors that helps to kind of potentiate that vasoconstriction that you have in the vascular phase is something called thromboxane A2. So platelets, they release this thing called thromboxane A2, which you see right here, which is a vasoconstrictor. And we're going to be talking about that at the end when we look at how aspirin works. So the platelet phase, we're going to form like a little platelet plug. The platelet plug is temporary, just kind of a little short-term fix until we can form a clot. The platelets release a number of different factors that help prevent blood loss and to initiate the clotting process. They release, we had mentioned thromboxane A2, but they also release something called serotonin. Both of those contribute to vasospasm, so they're vasoconstrictors, so they act on the smooth muscle. ADP, that stimulates the aggregation of the platelets, because you need to bring in more platelets, and you need to get them to form that little plug. They need to stick together, and secretion of substances from the platelets, which again will contribute to the stopping of the blood. The PDGF is platelet-derived growth factor. That's going to be released to start to initiate the repair of the blood vessel, because it tells you what it does. It's derived from the platelets. Growth factor, you're going to need to repair the vessel. The last one is calcium. Calcium is also released by the platelets, and calcium is absolutely essential for the clotting process, and we're going to show you that when we look at the pathways, and aggregation of the platelets. So that's what calcium's for. It's for clotting, the coagulation cascade, and for additional aggregation of the platelets. So you start with the vascular phase. That's very quickly followed by the platelet phase, and within 30 seconds you started the coagulation phase, in which you're actually going to form a blood clot. That's what the coagulation has to do with. It is, I had mentioned, is an example of a positive feedback mechanism. This is going, when you trigger this coagulation phase, it's designed so that the process runs faster and faster and faster until the bleeding actually stops. The major, or I should say the major event is this one right here. Fibrinogen, which is normally is floating around in your bloodstream, it's soluble. That will be converted into an insoluble substance called fibrin, which helps form the meshwork of the clot, which will trap platelets. It'll trap some red blood cells. That is the ultimate major event, and we're going to show you what is needed to convert fibrinogen to fibrin. Now there are a number, I'll show you, here's what a blood clot looks like. So you can see all the fibrin fibers, the trapped blood cells, and the platelets, so that's kind of cool. Now a number of clotting factors are needed for coagulation, and do not worry that you're going to have to memorize all these clotting factors. If it's a certain factor, I'm going to tell you need to know it. You'll notice that calcium is listed here. And I'd say that's one of the things you absolutely need for clotting. And it is so important that it actually gets its calcium, but they actually call it factor 4. That's why it's considered so important. They even give it its own name, factor 4. All except for about 3 of the clotting factors are produced in your liver. So people with liver disease will have clotting problems because if the liver's not functioning right, it won't be able to produce a lot of the clotting factors. What you'll notice on the picture, it depicts these 3 pathways: extrinsic, intrinsic, and common. The extrinsic and intrinsic pathways will ultimately converge on the common pathway. And here's that very important last step that I said. Fibrinogen is converted to fibrin, and what converts it is thrombin. So make sure you definitely know this step here. So thrombin will convert fibrinogen to fibrin. So you'll notice like ogen at the end of something here, or pro in front of something. Those, if you see ogen at the end of a word or pro in front of a word, it means it's not active. It's like a precursor. So what happens in these pathways is you have something that's inactive, but then converted to something that's active, then acts upon another thing, and it's a cascade. And eventually you get that fibrinogen converted to fibrin. Now, I wanted to show you, compare and contrast the 2 pathways for initiating clotting, the extrinsic pathway and the intrinsic pathway. The extrinsic mechanism, or extrinsic pathway with an E, is triggered by damage to the blood vessel wall. So the initiating factor that's not normally found it's not in the bloodstream, it's in the tissue. If you damage a tissue wall, the initiating factor is called factor 3, or I'll have it written down here, is tissue thromboplastin. I actually like that one better because I hate trying to memorize factor numbers. But I do want you to know this one, and when you look at this one too. Tissue thromboplastin is going to be released when blood contacts that damaged tissue. The tissue releases factor 3. Intrinsic mechanism, it's initiated when blood contacts a foreign surface. So in our bodies, what could happen is you maybe had a atherosclerotic plaque that somehow became dislodged or exposed some of the collagen of the blood vessel wall, which normally should not be in contact with the blood. We should have an endothelium that lines the blood vessel. So the blood contacts that foreign surface. It says, hey, this isn't right. I need to initiate clotting. And so here, the factor 12, or Hageman factor, is going to be the initiating factor. So we go back here. So you see the intrinsic and you see the extrinsic pathways. And here's your factor 12 right there. So the big differences between the two is extrinsic, the initiation of clotting happens because of damage to the wall. And the chemical that initiates it is found not inside the blood. It's normally outside of the blood. So that's why you can extrinsic think outside. The intrinsic pathway, The chemical that needed to initiate it is normally found inside the blood. So intrinsic pathways, everything you need to be able to clot the blood is normally inside the blood. But here the blood has contacted a foreign surface. Both pathways ultimately, actually I'm going to come back here so you can see it, ultimately will converge on that common pathway. So they both, if they're initiated, will eventually converge on that common pathway. But I do want to go over some differences between the two, or some similarities too. Is if you damage a blood vessel wall, both the intrinsic and extrinsic pathways will be involved. The only thing is the extrinsic would be initiated first. It's very quick, it's a little bit shorter, but at some point it will come over and activate the pathway for intrinsic. Not at the initiating part that you saw with the factor 12, but it will bring in the intrinsic pathway. And so, but if the intrinsic pathway is initiated, you won't get the extrinsic pathway initiated. The intrinsic is actually needed with tissue damage because you need a lot more of that thrombin, and you get a lot more thrombin from the intrinsic pathway. And thrombin, remember, converts fibrinogen to fibrin. The couple things that are important to realize in the pathways is calcium is absolutely required in all of the three pathways, the extrinsic, the intrinsic, and the common. Calcium is an important cofactor needed for some of these reactions that take place. So if you're deficient in calcium, you'll have a problem with blood clotting. So people with hypocalcemia have issues with blood clotting. Often, if they need to take a blood sample and they want to measure something, but they don't want the blood to clot, they can put something called EDTA in the tube, and that works as a calcium chelator, which will bind up the calcium so then the blood won't clot in the tube. Another thing that's needed to make some of the clotting factors is vitamin K. Vitamin K is made by your liver. So if you have liver problems or you have deficiency in vitamin K, you're going to have problems with blood clotting. So vitamin K is necessary. Often you hear about people, if they're going to go into surgery, sometimes they'll get vitamin K shots just to ensure they have sufficient levels of that to make sure they have plenty of the clotting factors needed. Now here, kind of how it shows you that we have that kind of some of the steps that we talked about. You got the platelet plug, the platelets aggregate. They're going to initiate factors that help to activate coagulation. You start forming the clot. Remember that major event is the conversion of fibrinogen to fibrin. But shortly after that, you actually want to pull the ends of the vessel wall together, and the clot actually will start to retract. So it pulls. So if here's the cut vessel, these are going to be starting to pull the vessel together. And also, at some point in time, you do want to dissolve the clot. Once the blood vessel is repaired, you need to start dissolving the clot. So we need something called fibrinolysis. During the clot retraction, as the walls are pulled together, this thing we call serum is squeezed out. All serum is your plasma, but without the clotting factors. So sometimes some blood tests are done on serum, so they will actually draw your blood in a tube that doesn't have any type of anticoagulant in it, and they allow the blood to clot, and they'll spin it down and just remove the clot and just have the serum that's left over. The PDGF, platelet-derived growth factor, that helps to repair the wall. Now, another thing that's going to see is, how are we going to help to dissolve the clot? So I have this picture to help show you a little bit better, the fibrinolysis. There is something called plasminogen. That plasminogen is absorbed by the clot. And there's something that's produced by our blood vessel walls, the endothelium of the blood vessel walls, called tissue plasminogen activator, or the TPA. That will convert plasminogen to plasmin, and plasmin actually will be involved in digesting the clot, breaking it down. These FDPs you see here, that's just fibrin degradation products. So it's in breaking down the clot itself. So the tissue plasminogen activator helps convert plasminogen to plasmin, and then the plasmin actually digests the clot. Sorry. Now this is going to be very important in our discussion at the end, and I'm going to be mentioning also about the importance of the endothelium, or an intact endothelium, very shortly. The question is, what keeps blood from just clotting willy-nilly, or what also, you got a clot form, what prevents it from spreading? Why it needs to be localized. We don't want to initiate a blood clot and then it travel throughout your bloodstream. Is one of the things that we have in place, or we have this system of checks and balances, is blood vessel walls. The lining is endothelium, and if it's an intact lining, that under normal conditions discourages the accumulation of platelets. You see we have that tissue plasminogen activator that's produced by it, but also that's short for nitric oxide. Endothelium, or endothelial cells, produce nitric oxide, which is a vasodilator, but it also inhibits platelet adherence. So it's an anti-platelet factor, antithrombotic agent. Also, if we do have a clot that forms, what you saw earlier, that fibrin absorbing the thrombin and thrombin, and then also the thrombin, which converts fibrinogen to fibrin, it won't be spread, but also what we looked at in regards to the plasminogen being converted to plasmin, and then it helps to digest the clot. And knowing various factors that are involved in breaking down a clot or may act as anticoagulants, we can use that to our advantage in clinical scenarios. So we're going to mention a few of those in a little bit. Actually, here. So here, let's talk about some of them. Tissue plasminogen activators, naturally produced by the endothelium. It's used to dissolve coronary thrombi. So it's very expensive. The individual that comes in with a suspected coronary thrombus, they need to have been identified very early on, because otherwise it really won't help them. So if someone has a heart attack and as a result of a blockage of a coronary artery by a thrombus, they will utilize tissue plasminogen activator. Another naturally produced substance is heparin. You already learned about that with the basophils and the mast cells. That is a natural anticoagulant, and it's actually used pharmacologically. Prostacyclin is also naturally produced. Endothelial cells produce those. And a couple other things. Actually, I'm going to jump to aspirin. Aspirin is low-dose aspirin therapy is often given to people to try to prevent blood clots, is because it inhibits enzymes that are needed for the production of thromboxane A2. And at the beginning of the lecture, we talked about thromboxane A2 acting as a vasoconstrictor. So that's one of the things it does, is it inactivates the platelet's ability to produce thromboxane A2, but also prostaglandins, which aid in blood clotting. Another, this is going to be definitely a pharmacologic agent, aspirin is pharmacologic too, is something called warfarin, or it's referred to as Coumadin. This is a substance that is an antagonist to vitamin K. So here, if you antagonize vitamin K, you will not produce some of the clotting factors. Now this has to be carefully monitored. This is very often given to people to prevent thrombi. So this was one of the substances given to my mother relatively recently. She had multiple pulmonary emboli, and she was given certain drugs to help to dissolve the emboli that she had, but she's on relatively long-term Coumadin therapy to prevent any additional thrombi from forming, because she is very susceptible of forming thrombi. She has a certain condition that she produces thrombi quite a lot, especially if she's having any type of surgeries. So since I'm talking about thrombi and I had mentioned emboli, I want to just give you the distinction between them, some terms. If you have a thrombus, or thrombi is plural, that's just a blood clot. So you have a blood clot, it's blocking flow. So if it's in the coronary artery, it's going to lead to a heart attack. You could have a blood clot in your leg. Now, this is what happened with my mother. She had surgery. She developed a blood clot in her leg. Thing is, that clot then dislodged and moved through her blood. So she had an embolus. So the embolus, it means it's moving, hasn't blocked anything again. But once it went into her pulmonary blood vessels, she had pulmonary emboli. She had multiple ones. So an embolism is if this embolus then blocked the blood flow. So she started off as a thrombus, it moved, and eventually it blocked blood flow at a distant location. So she had an embolism. There are people there's a number of different blood disorders involved that causes inadequate blood clotting that are genetic diseases. People do have abnormal blood clotting if they have vitamin K deficiencies, if they've got liver failure, but here I'm going to talk about a couple genetic disorders. Hemophilia is an X-linked disease, so it most often affects males because males have only one X. Females who have two X's, they need to have two defective alleles in order to have hemophilia. So it's most often going to affect the males. And any of the clotting factors that we discussed could be deficient. So there's a number of different types of hemophilia. Most often it affects this factor 8. But this is what when you learn about in the past with the royal family in England, because they did marry their cousins a lot, and so there was a high prevalence of hemophilia in that family. Another one is something called von Willebrand disease. These individuals have a deficiency in von Willebrand factor. That's how you abbreviate it. This is a factor that helps to stabilize factor 8. So if it's insufficient, the factor 8 is not stable, and so they do have issues with blood clotting. It's not as serious as hemophilia, because hemophiliacs can just spontaneously hemorrhage. You have to, if they bump themselves, and most of us would maybe get a bruise, they would have a major problem as a result. Von Willebrand disease is also a inherited condition, and so they do have issues they have impaired blood clotting times. So this is going to be the end of the last webinar covering the blood.